Hello, my name is Andrew Buchanan, and I'm a student in APS 503 Advanced Medical Care under Dr. Lisa Clegg. And today I'm going to talk to you about seizure management. So seizures are defined as temporary, involuntary alteration in behavior, consciousness, motor activity, or autonomic function due to excessive rates and hypersynchronicity of discharges from a group of cerebral neurons. The type of seizure activity that occurs is dependent upon the part of the brain that is affected. In seizure disorders, such as epilepsy, the brain's electrical activity is periodically disturbed, resulting in some degree of temporary brain dysfunction. Interesting enough, generalized seizures account for 35% of the epileptic population. Generalized seizures can be further broken down into absence versus tonic-clonic, formerly known as grand mal seizures. So what is a generalized onset motor seizure? So we have several different forms of generalized onset seizures. We have tonic-clonic, which will be the main focus of today's presentation, and these are formerly known as grand mal seizures. We have clonic seizures, which are sustained rhythmic jerking, tonic seizures, which are generalized stiffening involving all limbs and without rhythmic jerking, atonic seizures, which equates to a loss of muscle tone, myoclonic seizures, which is equal to rhythmic jerking and is not preceded by stiffening, myoclonic tonic-clonic seizures, which are myoclonic jerking followed by tonic and clonic movement, myoclonic atonic seizures, which is myoclonic jerking followed by atonia, and epileptic spasms, which were previously known as infantile spasms. So what is a generalized tonic-clonic seizure? And that's going to be the main focus today. So it is seizure activity that typically involves the entire body. It consists of muscle rigidity, violent muscle contractions, and loss of consciousness. It can occur in any age demographic and can present as an isolated episode or as a chronic condition such as epilepsy. In generalized onset seizures, seizures originate in networks in both hemispheres, which is what makes tonic-clonic seizure activity unique. Awareness is usually impaired and consciousness is usually lost. So seizure initiation is characterized by two simultaneous events in a group of neurons. The first, a high-frequency burst of action potentials, followed by hypersynchronization. And as you can see in the diagram to the left, which we'll explain further on in the presentation, there are three unique phases of a generalized tonic-clonic seizure. It includes a tonic phase, a clonic phase, and a postictal phase. So normal versus abnormal neuronal signaling in the brain. So normal signaling in the brain is a very complex sequence of pre- and postsynaptic events that are mediated by intracellular signaling and gene expression pathways. So when normal signaling goes astray, what happens? We start to develop pathological conditions such as epilepsy. And this is the abnormal signaling that leads to aberrant cellular and network activity that produces a shift in the connectivity and synchronicity that leads to disease progression. On the diagram to the right, you can see neural activity during a seizure. So we have normal neural activity, followed by abnormal neural, the rapid firing, rapid discharge of neuronal activity that produces the signs and symptoms that we see with seizures. So the pathophysiology of seizures. So seizures are thought to arise secondary to an imbalance between excitation of inhibition of neurons. This imbalance of excitation and inhibition results from alterations in genes or from acquired etiology, which we'll talk about further on with the causes of seizures. So genetic pathologies produce dysfunction at the circuit level, abnormal synaptic connectivity, to the receptor level, imbalance between excitatory glutamate and inhibitory gamma aminobutyric GABA receptors, all the way to ionic channel level. Acquired cerebral insults such as trauma, strokes, or tumors can alter cerebral neuronal circuits similarly. So at times, when the epileptogenic neurons overcome the surrounding inhibitory influence, the seizure discharge spreads to neighboring cortical structures and then to subcortical and brainstem structures, therefore passing over several different brain hemispheres and giving us the presentation of a grand mal seizure, also known as tonic-clonic. So how does glutamate play a role in the brain? So glutamate is the predominant excitatory neurotransmitter in the adult brain. So seizures, therefore, induce elevations in extracellular glutamate, which then contribute to the excitotoxic damage in the brain. Chronic seizures suffered by patients, therefore, can alter neuronal and glial expression of glutamate receptors and uptake transporters. Glutamate can be inhibited by decreasing its release from the presynaptic neuron or preventing the postsynaptic neuron from responding. As for inhibiting the release of glutamate, one could inhibit calcium channels of the presynaptic neuron that allow the calcium influx that leads to synaptic vesicle fusion and release of neurotransmitter. So we discussed glutamate, and we also need to discuss how GABA plays a role within the brain and with the pathology of seizures. So GABA is an inhibitory neurotransmitter that produces a calming effect. So if we have a lack of this amino acid, or if we have a GABA receptor dysfunction in the body, this can all contribute and lead to different types of seizure activity. Increasing GABA efficacy, therefore, can treat excitatory neuron activity. So to increase GABA or its effectiveness in the body, one can decrease synaptic degradation of GABA or block GABA reuptake in the presynaptic neuron. So benzodiazepines and barbiturates act at the postsynaptic chloride channel where GABA acts. Therefore, they enhance chloride influx, thus increasing inhibition of these neurons. And we'll talk a little bit more about the pharmacology aspect and how this works later on. So clinical features of seizures. So seizures can present with a sudden change in awareness, ranging to full loss of consciousness, typically preceded by cognitive or emotional symptoms, such as fear, anxiety, unusual thoughts or sensations. Patients may or may not have what's called an aura, and this describes how a patient feels before a seizure starts, and this can consist of things such as motor activity, sensory, autonomic, or psychic sensations. We have our tonic-clonic phase, loss of consciousness, a general muscle contraction and rigidity, so the tonic phase, which is lasting approximately 15 to 20 seconds, but changes in every patient. We have aggressive rhythmic muscle contraction and relaxation, the clonic phase, and that can last approximately 1 to 2 minutes. Factors such as biting the tongue, biting the cheek, trismus, and incontinence. Our postictal phase, retrograde amnesia, headaches, followed by fatigue, drowsiness, and confusion. So what are the phases of a tonic-clonic seizure? So as we talked about the aura phase, so this is initially where a patient may feel lightheaded, dizzy, confusion, or have certain hallucinations, sight, smells, tastes, things like that precede their seizure. And then we go into the tonic phase. So the tonic phase is a spread of excitability to subcortical thalamic, brainstem, and spinal cord structures. The tonic phase can present with signs and symptoms such as skeletal muscle tense up, jerky movements, and usually when the patient starts to lose consciousness. The clonic phase is discontinuous bursts of electrical activity brought about by the interruption of the tonic phase by an inhibitory impulse which starts from the thalamus. This can include convulsions, violent shaking, uncontrollable twitching, and sometimes apnea. In our postictal phase, we have weakness, a unique transient paralysis, also known as Todd's paralysis, that is a temporary paralysis during the postictal phase, confusion, drowsiness, headaches, muscle aches, and fatigue. So I'm going to show you an example here of a grand mal seizure. I'm sure many of you have seen this in your practice, but in case you haven't actually seen the unique phases, I brought up this video. So this is types of seizures. And again, this is only for educational purposes. So this is a generalized tonic-clonic seizure. So the seizure activity starts, we have our tonic phase, followed by our clonic phase, seizure activity then stops, and the patient begins to transition into the postictal phase. So what are our causes of seizures? So our main causes of seizures are epilepsy, heat exposure and fever, hypoxia, structural, for example, head trauma, tumors, or abscesses, electrolyte imbalances such as sodium, calcium, phosphate, or magnesium, endocrine causes such as hyperglycemia or thyroid storm, withdrawal symptoms from alcohol or illicit drug use, toxic ingestion such as sympathomimetics, TCAs, cholinergic, anticholinergic, serotonergic agents, neuroleptics, and aspirin, medication, typically non-compliance, stroke, ischemic or hemorrhagic, eclampsia, or infectious disease processes such as meningitis, encephalitis, or sepsis. So I found this really neat chart. This is produced by the Calgary Guide, a group of physicians in Calgary, Alberta. And I found this as a really strong educational tool that helps show us the different causes of seizure and how they all sort of conform together and what pathways they lead to and how they can lead to different types of seizures down at the bottom. So as we talked about on our previous slide, infection, neoplastic, cerebral vascular trauma causes, metabolic, toxic, or other causes. Whatever the cause may be in the body, it leads us to this middle pathway that guides us to a point of altered neuronal excitability, which we talked about in the pathophysiology section. Therefore, then leads to an altered communication between the cortex and the subcortical structures of the brain. An overall increase in excitatory tone producing aberrant cortical electrical activity, followed by cerebral hemispheres synchronously and spontaneously depolarizing as the electrical signals spread diffuse through the brain tissue. And this can lead to three other pathways, whether it be strictly motor, generalized, or non-motor seizure activity. So physical examination. So things we're looking for are abrupt loss of consciousness, loss of muscle tone. In the primary phase, we're looking at muscle rigidity, tonus, less than a minute. Secondary phase, we're looking for clinic or jerking activity. Eyes gazing to one side, nystagmus. Snoring respirations with poor air entry. Skin may be pale and cyanotic. Incontinence, tongue-cheek biting, followed by a lengthy postictal period. History taken in special populations within the seizure group. Some certain history questions to ask include, is there any illicit drug or alcohol use or withdrawal symptoms? Have they been admitted to the hospital for detoxification in the past? Are they currently compliant with their medications? Is there any new changes or new doses to their medications? Do they have a history of HIV? If the patient may be pregnant in the third trimester, do they have a family history of preeclampsia or eclampsia? Do they have a seizure disorder history? Status epilepticus history? And as a reminder, a status epilepticus is defined as seizure activity that's equal or greater to 5 minutes or 2 or more seizures without regaining consciousness between seizures. So one thing as practitioners, as we start to develop a stronger understanding of the physical exam and history taken of a seizure, is ruling out a true seizure versus another cause of obtundation such as a pseudo-seizure or syncope. And one of the key things to always remember in our history taking and physical exam is always remember in patients who suddenly lose consciousness that we need to consider global brain ischemia even if observers report myoclonic jerks. So pharmacology. Benzodiazepines are considered the first-line agent for rapid seizure control. Commonly used drugs in the field, pre-hospitally, and in the hospital include Ativan, Versed, and Valium. So how do benzodiazepines stop a seizure? So benzodiazepines bind to the benzodiazepine site on neuronal GABA receptor complex. This enhances GABA-mediated chloride influx that you can see in the diagram below. Effects include sedation, skeletal muscle relaxation, and anticonvulsant effects. Benzodiazepines are used in patients with continuous or very frequent seizures to temporarily control the seizure until more specific agents can be given. So what other options do we have in the toolbox? So anticonvulsant therapy can include secondary medications such as Dilantin, carbamazepine, phenobarbital, and primidone. So Dilantin and carbamazepine work by reducing sodium, calcium, and potassium currents across neuronal membranes and is indicated in all types of seizures except absent seizures. So phenobarbital, which is a barbiturate, binds to the receptor adjacent to GABA receptor on chloride channels. This results in the retention of GABA and its receptor causing increased flux of chloride through the channel. This effect induces sedation, euphoria, and mood alterations. But this drug does not come with low risk. At high doses, this drug can cause cardiovascular depression, respiratory depression, and death. And this is why benzodiazepines are preferred over barbiturates. So other principles of anticonvulsant therapy include increasing the dose of the suitable agent until desired effect is achieved. A second drug may be added, or there's an abrupt discontinuation of anticonvulsant therapy that may induce status epilepticus. One of the other things to remember too, that if the patient has a history of preeclampsia and especially developing into seizure activity with eclampsia, magnesium sulfate is indicated for its smooth muscle relaxant effects, alongside benzodiazepine treatments such as midazolam. So as a protocol review, I want to walk through our seizure protocol. So as always, we start with a standard approach and ongoing assessment. Appropriate PPE must be applied. We must obtain point-of-care testing with our iStat device and consider potential causes for our seizure. Is our BGL less than 4? That will walk us down our diabetic protocol and treat accordingly. Is the patient in third trimester or postpartum? We can refer to our preeclampsia and eclampsia protocol. And again, if we're having seizure activity within this demographic, we have orders that include frontline treatment of midazolam, as well as concurrent treatment with magnesium sulfate at 4 grams IVIO over 20 minutes, followed by 2 grams an hour, either IV or IO. In our demographic of seizing patients as well, our frontline treatment is our benzodiazepine, as the research has shown this is the most effective in frontline seizure management. We have orders for midazolam at 0.05 milligrams per kilogram, either IVIO, to a max dose of 5 milligrams, and this can be utilized Q 5 to 10 minutes PRN. If we are unable to obtain vascular access, we also are allowed to administer midazolam 10 milligrams intramuscular. If the patient remains in status epilepticus, we must consider advanced airway procedures. As a reminder, propofol and midazolam infusions are preferred for this patient demographic. In the event that the patient is continuing to seize, our next algorithm moves down to dilantin. And again, we must consult our transport physician for orders. And this comes at 20 milligrams per kilogram, IVIO, and is diluted to a maximum concentration of 10 milligrams per mil. And again, this is weight-based, which you can see are 3 different categories below. Again, if this second treatment isn't working, we must consult our transport physician to consider other agents such as phenobarbital, valproate, ketamine, and inhalation anesthetics. Relevant investigation. So, as our protocol called, we have the ability to do point-of-care testing with our iStat device. So while utilizing our point-of-care testing, look specifically at sodium, calcium, and glucose levels to help identify the cause of the seizure. And always remember that elevation of lactate is an expected finding. Other things to help rule out include hypoglycemia, eclampsia, hyponatremia, and hypocalcemia. And if ever in doubt, please reach out your findings to a transport physician to discuss treatment plans accordingly. Transport decision making. Always call for backup early. In the status epilepticus patient, it is imperative that we have a great deal of practitioners to be able to help with things such as advanced airway management, if indicated. Always provide early pre-notification to the hospital. Consider your transport time. And is air ambulance available? So are we out in a rural environment? But also we need to consider, is our patient safe for flight? So leadership role, crew resource management. So the 6 principles of crew resource management can include factors such as situational awareness. So what environment are you in? Is your patient safe? Is your crew safe? Communication. So having clear, effective communication with your crew where closed loop is preferred. Task management. So delegating all tasks to the appropriate personnel, coordination. What else may need to be done for patient care? Planning. Do you need more resources? For example, an air ambulance for long transport time. And one of the big ones I want to highlight is decision making. So always thinking 2 steps ahead approach. So always be ahead of the what if scenario. I would like to thank you for listening to my seizure presentation today. I would like you to see my list of resources. If you have any further questions, please feel free to reach out. And thank you for sharing your time with me.